Good day, everyone. I'm Christine Cadag, and I'm going to discuss about endotracheal intubation. So the teaching strategy that I'm going to use today is traditional audiovisual PowerPoint slides. For any questions and clarification, you can email me at christinelcadag@gmail.com. So let's start. Our learning objectives are learn the definition of endotracheal intubation, discuss indication for intubation, learn about the equipments needed for intubation, learn about the steps in intubation, explain potential risks of intubation, discuss about the nursing care of an intubated patient. So what is endotracheal intubation? So this is a medical procedure in which a tube is placed into the windpipe or trachea through the mouth or nose. In most emergency situations, it is placed through the mouth. So this is how an endotracheal intubation looks like, as you can see on the right side. So what are the indications for intubation? First, to secure the airway includes respiratory failure, hypoxic or hypercapnic. So hypoxic means decreased oxygen or low oxygen in the body tissue. And for hypercapnic, it is an increase in partial pressure of carbon dioxide or PaCO2. So if the carbon dioxide is above 45 millimeter of mercury, that is hypercapnia. The normal for PaCO2 is 35 to 45. Next is apnea or cessation of breathing. Reduced level of consciousness, sometimes stated as GCS less than or equal to 8. Rapid change of mental status, airway injury, or impending airway compromise. Next is high risk for aspiration or trauma to the box or larynx, including all penetrating neck, abdomen, or chest injuries. So what are the equipments for intubation? As you can see on the right upper corner of the screen, there are the equipments needed for intubation. First is the laryngoscope handle, an instrument used to visualize the larynx. So this is paired with a blade or laryngoscope blade, which comes in two types, the Macintosh and the Miller. Macintosh is the curved one, and Miller is the straight one. Cough endotracheal tube, a catheter that is placed inside the trachea to maintain patent airway. So endotracheal tube also comes in two types, coffin and cuff. Usually, cuff is used for adults, while for children and pediatric, it depends on the age. You can use cuffed and uncuffed. Stylet, a probe that assists with intubation. So it is also called guide wire. Next is large oral airway, a device that opens up airway by preventing the tongue from covering the epiglottis. So there are large oral airway for adult and small oral airway for pediatrics. Next is nasal airway, similar to the oral airway but goes with the nose. Young person suction tip. This is an oral suctioning tool to clear up the secretions inside the mouth before putting the tube. Next is major forceps, aid passage of endotracheal tube. Face mask. It is also used for hyperoxygenation of the patient by ambu bagging before intubation. Next is face mask, syringe. Then syringe is used for inflating the cuff to prevent air leak. Next is carbon dioxide detector, a device that's used to check the position of tracheal tube by measuring exhaled carbon dioxide. Followed by tracheal light. So tracheal light is also called the light one. It is also known as illuminated stylet that used to insert the endotracheal tube, and the tip of the tube is directed into the trachea, guided by translumination of the neck tissue. So this equipment is used for easy visualization of the neck tissue while inserting the tube. Next is Muji, similar in function to a stylet, but it is more elastic. So who performs intubation? Intubation can be performed by various healthcare professionals such as physician, anesthesiologists, nurse anesthetists, and other advanced practice registered nurses. So before a person can perform intubation, they should have a certification that they have undergone an advanced practice. This is for uh, this is to make sure that the patient is safe on their hands. Next is steps in endotracheal intubation. So before intubation, the patient is usually sedated or not conscious, allowing their mouth and airway to relax. They often lie on their back while the healthcare professional stands near the top of the bed facing the patient's feet. So the physician or the doctor will position himself near the top of the bed for easier visualization of the trachea during intubation. The patient's mouth is gently open using an instrument to flatten the tongue and illuminate the throat. The tube is stirred into the throat and advanced into the airway. So that is how you insert the EPP. A small balloon around the tube is inflated to keep the tube in place and prevent air from escaping. Once this balloon is inflated, the tube must be tied or taped in place at the mouth. So once the doctor inserted the EPP, the nurse will inflate the cuff. This is to prevent air leak. And then after securing the position of the EPP and checking the level, the lip level of the tube, it should be secured properly on the side of the mouth. Next, for successful placement is checked by listening to the lungs with a stethoscope and can be further verified through a chest X-ray. So after intubation, the doctor and the nurses will check the breath sounds if it's equal, and they will also observe the chest rise of the patient. After that, they will order an X-ray to check for the position of the tube. And after that, maybe after 30 minutes, they will ask for an ABG or the arterial blood gas. So next is, if faced with the problematic airway, call for the difficult airway part and ask experienced colleague to help. Note pre-oxygenation and monitoring during awake intubation is important. So what is the meaning of awake intubation? So it's used in patients with a predicted difficult airway or unstable cervical spine. So during intubation, the patient is awake, and if the intubation failed, they will stop doing it and the patient can help himself to breathe. This is to prevent the saturation of the patient, especially if the patient had experienced difficult intubation before, or maybe if the patient will, for example, there is some uh, structure on the throat that makes it difficult for the doctor to intubate the patient. Next, the tube is much easier to remove than to place. So here we're talking about extubation. So prior extubation, there are also preparation for the patient. So first NPO for 4 hours, then the doctor will order to taper the sedation, and gradually they will decrease the ventilator setting. Usually, if the patient is completely sedated, they will put the patient in control mode or PCV mode. Then after that, the setting of the ventilator will be decreased to pressure SIMD and then to CPAP. So before intubation, if the patient is almost wind of the sedation, you need to explain to the patient what is going to happen, so that he will be able to prepare himself mentally. And then as nurses, you need to put all the all the materials needed, all the equipments needed if there is any possible reintubation. Also, you need to prepare at the bedside, O2, nasal cannula, ambo bag, suction tip, those kind of things. And also, ETT of the same size if there is any possible reintubation. If the patient will not be able to tolerate the extubation process. So first, remove the ties or tape that hold it in place. Then deflate the balloon so that the tube can be carefully pulled out. Okay, next potential risk of intubation. Trauma to the teeth, mouth, tongue, and or larynx. So before intubation, you need to check if the patient is wearing dentures and if there's any moving tooth. So you need to remove the moving tooth ahead of time so that it will not get dislodged and block the airway. Next is accidental intubation in the esophagus, or we call it esophageal intubation. So the ETT should be placed in the air tube or the trachea and not in the esophagus. So if there's an accidental esophageal intubation, you can see that during ambobagging, the abdomen of the patient is increasing in size. So you need to, if esophageal intubation happened, you need to remove the tube and reinsert another tube again. Next is trauma to the trachea and bleeding. So if there is trauma, there is bleeding and you can see it immediately. During suctioning, you can see that blood is coming out. And also you can see sometimes during emergency situation, blood is coming out on the patient's face, mouth, nose, those kind of things. Next is inability to be weaned from the ventilator, requiring a tracheostomy. So if the patient is intubated for a long time, the doctor will require or suggest a tracheostomy. So the patient will be tracheostomized. It is usually common among patients who are in vegetative state and those who are bedridden. Next is aspirating vomit, saliva, or other fluids while intubated. So that's why before extubation, before intubation, the patient is kept on NTO, or if there's any gastric content, the nurse will remove it. So the patient will not vomit during intubation. Also, if the patient is vomiting, the patient might aspirate, and this may cause pneumonia. Next is sore throat and hoarseness. So right after extubation, the patient will experience sore throat and hoarseness, and this is pretty normal, and it will improve after a few days. Erosion of soft tissue with prolonged intubation. Patient who have been intubated for a long time might have erosion of soft tissue, especially inside the mouth, in one of the corner of the mouth. So as nurses, we need to reposition the tube regularly. After a few days, for example, it's on the right side of the mouth. The patient, the nurses can put it on the other side. Next is nursing care of intubated patient. So first, never leave the patient alone. Check the ventilator setting. Immediately after the intubation, the patient should be monitored closely. You need to observe as nurses if the patient is saturating well and if he is tolerating the ventilator setting. You need to note the heart rate, the RR, the color of the patient, if the patient is perfusing well or not. Also, you need to check the ABG result, and if there's any abnormal result, you need to immediately tell it to the doctor. Next is watch and maintain an open airway. So you need to suction as needed to maintain an open airway. Next, prevent the displacement of the tube. So the ETT, once inserted, should be secured properly. And if the patient is moving too much, you need to increase the sedation as needed, and also inform the um, anesthetist. Next is watch for complications such as laryngeal edema, tracheal stenosis, and hemorrhage. Observe the patient's tachypnea, tachycardia, diaphoresis, and hypoxia. So you need to check the vital signs of the patient because this will be the indicator if the patient is saturating well, if the patient is tolerating the ventilator setting. So if you see that the heart rate is increasing, the RR is increasing, the patient is uh, profusing too much, and the O2 saturation is low, you need to check first if there's any secretion, reposition the head, and then check if the ETT is blocked or kinked. And if all are okay, you need to immediately tell it to the doctor. Maybe he will adjust the sedation or the ventilator setting. Next is maintain patient head elevation 30 to 45 degrees for prevention of aspiration. Keep an emergency tracheostomy tray with tracheostomy tube, the correct sizes at the bedside for emergency patient care purposes. So there are incidents for tracheostomy patients who are ventilated that they will try to remove the tracheostomy tube. So there should be a tracheostomy tray at the bedside so the patient will be able to, so that the nurse will be able to insert the tracheostomy tube if there is any accidental dislodgement. It is very common, especially for agitated patients or for small children who are tracheostomized. Next is documentation and procedure details in the patient record. So as nurses, we need to be careful with the documentation. We know that if it's not written, it is not done. So starting from how you see the patient, the ventilator setting, the size of the ETT, the ongoing sedations. So you need to note all of that. And also remember that there should be a set, an intubation set or same tube size that same as the patient is using. So if there's any accidental extubation, sorry, if there's any accidental extubation, it is easier for you to call the doctor and insert the EPP immediately. And also, it is very important that all the it is also important for the nurses to watch the patient closely and record the changes if the patient is tolerating the settings or not, if the patient's condition improved or not. So you need to check it properly. So these are my references. Thank you for your time, and if there's any question and clarification, you can email me at christinealcada@gmail.com. Thank you for listening. Good day.